First of all, greetings from New Orleans and from Tulane Urology. I am honored to be part of your program and thank you for inviting me to present. On behalf of the AUA, I would like to take this opportunity to invite all of you to the annual meeting this September in Las Vegas. We've moved it from May through September. I'm looking forward to seeing hopefully some of you in person at this meeting. We are talking about the surgical management principles, and I'm going to incorporate some of the guidelines for renal cell carcinoma. The incidence is 3% and increasing. Over 50,000 new cases arising from the proximal tubules of the kidney, and there's a 3% year-to-year increase for the Caucasians and 4% for those of African American heritage. Treatment depends on the stage, whether it is localized, above 7 centimeters, into the cava, metastatic, and so forth. It's not the top killer, but it is in the middle. Worldwide, a lot of these cases still go diagnosed late. Mostly in men. They also increase with age, though we're seeing younger patients now. They have a familial component, especially first-degree relatives. And there are, as you know, the main type is the clear cell renal cell carcinoma. We also have the papillary and the chromophobe type. When you're looking under the microscope, the histology includes the nuclear grade, whether there are sarcomatoid features, any vascular invasion, tumor necrosis, and so forth. The Fuhrman nuclear grade is widely used and is important. There are other renal tumors, for example, this acquired cystic disease, papillary adenoma. There's a hereditary, like the VHL. The angiomyolipoma and the oncocytoma are benign, even though they may take a big chunk in terms of size. So you need to make sure that you are following these small ones very carefully. These tumors, as those with experience in the audience know, it is a very, very vascular tumor, and that's why some of the chemotherapeutic agents are meant to take care of that as well. 50% and increasing are detected incidentally in the emergency room or with the CT scanning for something else. And the triad of pain, hematuria, and palpable mass is not quite as common. Gross hematuria is. And again, the guidelines, the AUA guidelines says that for diagnosing the solid or complex cystic masses, you require a high quality cross-sectional imaging platform. Because then we're looking at the tumor complexity, is there fat present or absent, enhancement with the Hounsfield units pre and post injection. And then if you suspect or diagnose the renal cell carcinoma, then you make sure that the metabolic panel, the blood count, chest x-ray are all negative. CT scan or MRI is the preferred mode right now, and you can see that this is how you diagnose an incidental renal cell carcinoma without any evidence of hematuria. And advanced cases such as the tumor thrombus within the vena cava can also be diagnosed. And as we move forward, the complexity is very important as we see the incidental, the advanced, and see where they fall in terms of the staging. The smaller the lesion, the better it is to treat, but you should be ready for all eventualities of taking care of these patients. Another guideline point is learn to know what the functional status of the patient's kidney function is. EGFR is important. If it is less than 45, then make sure that nephrology is consulted as a standby. If the patient is less than 46 years, then you should consider genetic counseling of these patients. Remember, these are something that the patients needs to know. Also, the diagnosis need not be confirmed with a biopsy. Okay, but we do have a role for biopsy if they are small masses that you are going to do active surveillance, or if you're going to be doing ablative therapy. Before the ablative therapy, whether it's RFA or cryo, you need to get the diagnosis. Is it metastatic disease? You need to know that because the treatment may differ if it comes back as a lymphoma, for example. The prognosis depends on the stage, the nuclear grade, as well as what subtype of renal cell carcinoma it is. One of the monumental changes in renal cell carcinoma is the minimally invasive surgical component. The rapid emergence of partial nephrectomy, for example, has been unbelievable and duplicable and effective. In many parts of the world, people do not have access to minimally invasive laparoscopic or robotic. And if the Bart Parker knife is all you have, so be it. You've got to do the best for our patients. And the initial description of the partial nephrectomy was using the Bart Parker. And then, of course, we got into the laparoscope and the robot. And you can see you can do just as good a job with the laparoscope if that's all you have access to. Kudos to Dr. Andy Novick, who taught us that partial nephrectomy is just as effective in those particular cases as total nephrectomy in outcomes. But saving the kidney was very critical. As many nephrons as you can. Indy Gill on the right side of the screen took it one step further and enhanced the concept of using the laparoscope initially and then the robot. The Da Vinci robot looks like it was made not as much for the prostate, but actually a wonderful job with the kidney in terms of decreasing warm ischemia time, using the suturing skills, and making sure that the partial nephrectomy was safely performed. Treatment options for renal cell carcinoma vary from radical nephrectomy to partial to ablative therapy to bench surgery. So the nephron sparing surgery is something that we got to think about very carefully. Any patients you see, can this patient be managed with a partial nephrectomy rather than a nephrectomy? The partial nephrectomy will decrease the risk of CKD or chronic kidney disease in the future. It is definitely to be stimulated for patients who have solitary kidneys, bilateral tumor, or non-familial RCCs. Prevent warm ischemia time as much as possible. Negative surgical margins are critical. And in select cases of familial RCC with multiple tumors, enucleation is very acceptable. Why is nephron sparing important? Because we have an aging population, more people with diabetes, hypertension, solitary kidney status who require the nephrons. Getting on dialysis is expensive and the quality of life is not good. Don't forget, there is a role for open surgical intervention as well. So here is the intraoperative ultrasound localizing the tumor. You can isolate the artery, and then using the scissors, you can remove the tumor with the appropriate level of margins. And then once you have removed it, then you can proceed with reconstruction of the of the kidney. You can use a two-layer technique like most of us do, is using the inner layer, and then once the inner layer has been taken care of, then we use the CT1 needle on a 0 or 2 vicryl sutures to proceed to close the defect. This has been one of the big advances, use of the Hemalock or any clips to put pressure on the kidney. And then you put the specimen in a bag and take it out. For a radical nephrectomy, what you have to make sure, if you use the laparoscope or the robot, you make sure your anatomy is well maintained. And then because of the wrist activity of the robot, it is much easier to get around the renal artery. And then once you have that, you can then use your stapler device. If you don't have a stapler device accessible, then you got to be facile with suturing the renal artery and the renal vein. Has that been done? Yes. So that is something that you will have to work with. Okay. And then, of course, you use a similar one on the renal vein. So for the radical nephrectomy indications, they are solid or complex Bosniak 3 to 4, and in high tumor complexity, hopefully with no pre-existing chronic kidney disease. They also have a normal contralateral kidney with eGFR exceeding 45. A lymph node dissection is done if it is indicated and concerning. Adrenal should be spared if at all possible, especially if the tumor is not in the upper pole. In the guidelines, it is said, both for partial nephrectomy and radical nephrectomy, the minimally invasive surgical approach is recommended as long as there is no compromise of the outcomes. Now, what do we do with the solitary kidney and tumors like this? And as you can see, that is a pretty significant one. These are the ones that we recommend to open up, do an open procedure, or if you're doing it robotically, then you have to be really move quickly to minimize the warm ischemia time. With open surgery, we use our hands to maintain the bleeding to be a minimum. Pelvic kidney with the auto transplantation is rarely done, but should be available as part of the armamentarium of managing renal cell carcinoma. What is the role of open surgery if it is large and you really cannot get around it with the minimally invasive techniques? No problem. Tumor thrombus in the vena cava and beyond, and of course we said solitary kidneys. So here, as you can see, is the tumor in the right kidney, and here it goes all the way into the atrium. We got a team with the cardiovascular, put the patient on cardiac bypass, and then opened up the atrium and removed the tumor thrombus. This is irrigated off very nicely once that is done. Beyond robotic partial nephrectomy or robotic nephrectomy, what is the role of active surveillance? Yes, there is a role for renal masses less than 2 centimeters, especially in the older age group. In the Bosniak 3 to 4 complex cystic mass, after you have weighed the risk and the benefit of this surveillance. There is a role for thermal ablation, especially for smaller lesions up to 3 centimeters. But we also recommend that a renal biopsy to confirm the diagnosis is made. You can use radiofrequency or cryo as options for ablation. Our medical oncology colleagues are increasingly helping us if there are concerns for metastasis, if the margins are positive, or if adjuvant treatment is to be offered. There are several of these agents that are now available, and your hematology oncology faculty will be ready to help you, especially the targeted therapies, anti-VEGF-Rs, and the mTOR inhibitors. There are several clinical trials available, and you can look it up online. We would be delighted to answer any questions you all may have. And you can see between the older sunitinib and the new ones, you can see there's a survival improvement. Follow-up, again, in the guidelines, we recommend abdominal imaging on an annual basis. After 2 years, you could resort to abdominal ultrasound unless the patient is very obese. After 5 years, it's a shared decision making. We recommend a chest x-ray in 6 months, 12 months, and then annually. In conclusion, there is increased use of partial nephrectomy. There is a real move to decrease the warm ischemia time. For bilateral tumors, you can use one side first, as I mentioned in my other lectures. We now have better outcomes measurements. All these techniques, including our medical oncology colleagues, have enhanced our ability to treat our patients. Thank you very much. I once again want to thank the organizers for making me part of the faculty. We'll see you in Las Vegas.